Great. Good morning, everyone, on this beautiful, snowy Vermont day. 10:15 in the House Healthcare Committee, and we're turning our attention today to some more testimony regarding the governor's proposed budget adjustment request of about $9.3 million for youth inpatient facility. And today, this morning, we'll hear testimony, and then this afternoon as well. But I'm going to first start with Devin Green from VAHHS to set the stage for us.
Sure, thank you. Devin Green from the Vermont Association of Hospitals and Health Systems, long time no see. So we just wanted to say that our hospitals support all resources going to mental health care. I think one of the more troubling issues that we've seen is youth waiting in emergency departments for long lengths of time. It is not good for the youth, as you'll see here, and it's also deeply, it causes a lot of moral injury to our providers as well. So there are reverberating effects. And so we support funding going towards this. We also support funding going to community providers. We know that the Department of Mental Health is doing a bunch of work in that area, and they have RFPs because they've received federal funding. So they are moving on supporting community providers as well. So we support this in the BAA as just a means of providing greater opportunities for the care in our mental health system. Today we have an emergency department nurse. He's a psychiatric APRN. If I have that right, Matt, sorry, hopefully. And so he can give you a perspective from the emergency department, and then a little bit after Matt will have an inpatient provider who can give you a perspective from the inpatient side. These are two individual providers. I'm sure you have a lot of questions about the system as a whole or institutions or anything like that. Feel free to direct those to me. For these folks, they're here to tell you what they're seeing as providers on the ground. So with that, I will go ahead and turn it over to Matt to introduce himself.
Great, thanks, Devin. Welcome, Matt.
Good morning. Thank you so much for having me. It's an honor to be here today to make the critical plea and need for the children of Vermont. My name is Matthew Dove. I'm a nurse practitioner that's dual certified in family medicine as well as psychiatric care across the lifespan. I work in the Brattleboro Memorial Emergency Department, as well as being the medical director for our HealthWorks Assertive Community Treatment team. I'll begin by saying that the goal of psychiatric care in Vermont in the emergency departments shouldn't be to make hell less hot. Increasingly, we see volumes and acuity in the emergency department that is so high. Regularly, 4 or 5 or even more children and adolescents are just waiting in our hallways in the emergency department. The demands on the department, there just simply isn't space for the folks that we serve to give them a room right now. We define and triage emergency medicine as trauma centers. And from that term, you can only imagine that the ED is not designed as a therapeutic space long-term for children. Yet facing crises, parents are so overwhelmed by the lack of resources in the state and in our care continuum that they would rather choose to have their child languish in the emergency department for days, weeks, and yes, in some cases, months, to keep a child safe for the promise of definitive psychiatric care. My colleagues almost daily ask me now, what can we do? Yet, despite the best frontline efforts by the excellent clinicians at BMH, the moral distress is that kids and families are still exposed to the spontaneously chaotic sights and sounds of an emergency. A parent once looked at me when their child was crying, shaken in the hallway, after just witnessing another patient screaming and saying to me, "This is not okay." Even more heartbreakingly, a child looked at me and said, having seen a patient come in from our ambulance bay having experienced a heart attack, they said, I should just go home and give up my bed. Other people need it worse than me, and I'm taking up space. So when I speak to families, and I do little more than apologize to them for the long wait times, they say that the gaps in care didn't just start in the emergency department. They tell me that the system as it stands is set up to fail. It feels like no one is seeing the big picture here. A parent told me it took a year to get developmental services. And they said even further, like, when you are so overwhelmed all the time and you have to keep sending appeal after appeal, you just give up. It took us 7 intakes to get an hour of therapy once a week. It wasn't enough. You can see where kids end up in crisis and go to the hospital just to get help. I want to amplify the voice of Vermont parents when I say that kids boarding in the emergency department is not okay, and we need your help. I would propose the critical need for increased infrastructure in the state and for a full continuum of psychiatric services for the youth of Vermont. I would advocate to you for 3 things today. Number 1 is that the most urgent improvement to the system would be to build more inpatient beds. We need to be able to build these beds as soon as possible, and would advocate that we please don't let these beds be held up due to lack of funding. The second thing I would ask for is staffing for these services. Increased bed capacity is one solution and very valuable, but we also have to invest in the Vermont workforce to keep staffing the beds and to retain professionals in the state. And the third thing I would ask today is that we would end up with an emphasis on upstream and downstream solutions in the community. Kim Edgar, a nurse and mother of a child experiencing neurodivergent needs in the Vermont system, reminded me that an increased resources would benefit both ends of the spectrum for our care in Vermont. Open access, easeful outpatient connection care would help to meet needs at a subacute level and to avoid the emergency room altogether. And in the same sense that once someone is about to discharge from inpatient hospitalization, the aftercare resources could help the discharge process and create a system that's durable to avoid further hospitalizations. As Ms. Edgar astutely reminded me, that the school systems should also be part of this continuum, and sometimes is often avoided or overlooked. In her words, schools are not equipped for mental health crises we're seeing now. She stresses the need for increased embedded providers in schools with expertise in substance use treatment, self-harm assessment, and trauma responsive care. I will finish today by amplifying the voice of parents and just saying that mental health care needs to be everywhere in our system at this point. Thank you so much.
Matt, thank you very much, not only for your words and for advocating for parents, but for all that you do in the emergency room and in caring for Vermonters. If you don't mind me asking, and feel free to not answer, but you've spoken for parents, but I'm really curious what the effects of what's happening in an emergency department is having on you and your coworkers.
Thank you for that. I want to make this about the patient experience. And I think that what you're describing is absolutely very, very important to talk about too, because it is driving people away from the work. I mean, I will be very blunt and honest with you that there are days like I didn't get home till 10 o'clock last night. And I'm trying to fight back tears thinking about some of those cases that I have seen, like during COVID, the mantra in the ED was like, there's no help coming where all there is. And we've worked really hard to try and stabilize and provide the best programming we can, but that's not good enough anymore. And I worry about the stress of seeing a child just waiting in an emergency department on our staff. I mean, that's one thing that as a psychiatric provider in the emergency department, I spend a lot of my time talking about trauma resiliency, but it's hard to continue to tell everyone like, keep your strength up in these moments when you just consistently see kids waiting every day, waiting for definitive care. So I appreciate you bringing that up.
Thank you, Matt. Do you mind a couple questions if there are any? Does anyone have any questions?
I have one.
Topper?
Matt, thanks for your work. Could you repeat your second ask?
Yes, of course. I think staffing is a really important part of this, and it's something that tends to get overlooked when we have the conversation about beds. Because one thing that we encounter, I think there's like 30 beds at the retreat right now, and often it's no fault of the retreats, but they're just saying we can't take anybody. We have short staffing. No one, someone called out tonight. And so we have a delay in care because there's just not a professional workforce to help staff some of these high needs, and I think we see that in the emergency department too. Like we would love to have more programming, but again, the point is not to make, this experience that is hellish less hot for people. It's to actually just get them definitive care. Like the emergency department really can't mobilize a program in it, for example. So staffing is a huge part of this. And I think there's some real incentives that could bring people to Vermont, like student loan reimbursement or forgiveness, and housing is another thing that comes to mind. But that's my second ask is really thinking about, in terms of these financial packages, thinking about ways to invest in the workforce of Vermont too.
Thank you.
Art, and then Leslie.
Yes, thank you. We've all been in the committee here for the last biennium, have heard about, for this will be third year now that I've heard about them, with children in emergency departments. And I'm trying to understand what types of problems children have that come in. And I know you can't be specific to maybe too much, but I'm really trying to understand what would drive a parent to bring a child into the emergency department at any hospital and leave them there for an extended period of time. It doesn't make sense to me that happens just on a parental level. And I'm trying to get at how severe the problem is, and is it something that just flared up, or is it something that's been with the child all the child's life and now has reached a head? And I'm trying to get my brain around that thing so I can process what you're doing. And I wonder if you could help me.
Absolutely. Yeah. Thank you for that. I think there is a multifactorial sort of approach here. And I don't think there's any one thing that we can say like, okay, someone is struggling with, depression, and this is why we're seeing an increase in that. I will point my finger at COVID and say that it was a collective trauma for everyone. And there was, loss of schooling. There was all types of things that sort of socially happened for folks too. And so I think that's a huge factor of that. I also think that our country, just to be frank, has not really invested in the infrastructure for mental health services. And so of course, these are, every system is designed perfectly to get the results it gets. So when you say about specifics, there are things that come to mind. I mean, I'm a parent too, and I think that what I've seen a lot with the folks that I talk to is desperation. Ultimately, the example I gave of like the parent sort of trying to get into outpatient resources, but they don't really exist. They're not there. There's no really like access. I think at one point I understood that there were like 3 outpatient psychiatrists in the state of Vermont working in child and adolescent services. So there's really not a lot of like clinical expertise to work with kids from a medication standpoint. And so it creates like these sort of bubbling situations where, a kid maybe has something like a reactive attachment disorder where, they have really difficult times with impulsivity and anger, and they get to a place where it's critical mass and they just can't find a way to find safety solutions at home. And so the emergency department is really the only choice left to keep them in a highly, structured in a way and safe and monitored environment. And that's sort of the benefit of inpatient hospitalizations is you work to stabilize, you work to maintain safety. And then once you've done those things, you can move to people to the aftercare environment. When there is no real robust aftercare environment, you just see sort of this revolving door process, right? The other thing that I think is happening that we have to recognize is that substance use is happening in younger populations, and these things can really drive care. It's hard to sort of wrap my head around that sometimes, but it is ubiquitous, and we're seeing a lot more and more of need for like substance use treatment. And so those are kind of the major things that I feel like are contributing to that. And I feel like parents don't have any choices at a certain point in time. And like it really does emphasize, I always talk about the emergency department as sort of the overflow tank of what a community needs. And, you see it kind of, what's not happening just sort of lives in the emergency department until we change it. And so I think that is the really desperate and sad conversation and choice parents make now is they don't have any real great options. They don't feel like they can keep people safe at home. And so they would rather choose to put them in an environment like the emergency department for days and weeks in order to get them stable and safe. So that's sort of how I would frame it. And I can certainly talk to depth on anything else that you feel like you need to know more about.
Thank you.
Thank you, Matt. Leslie?
Thank you, Matt. Leslie Goldman, and I actually come from Wyndham County, so I'm so glad you're here. We don't
Yeah.
often see people from the South, so thank you for that. I'm really interested in your third ask, the upstream and downstream services,
Yes.
particularly talking about the school system. And it seems like I'm thinking about the overlap of healthcare and education.
Yes.
And wondering if we as a committee should have some kind of interaction with the education committee to really figure out how to look at that. So I'm just throwing that out to you. I appreciate you bringing it up, but then are asking you as leadership to think about how we can work together with the ed committee to look at services and that, because I'll just finish by saying, that's where kids are. I think
Right.
that's what you're saying, right?
Right.
So in the healthcare, in the like primary care world, they're there for 15 minutes every so often, but in the school world, they're there all the time. So how do we integrate
So
that?
great question. And next week we will be having Department of Mental Health come in and provide testimony just around youth in the mental health system. Because if you remember, they came in and talked about adults and we never get past the adults to the youth. So we will have a focus time on the youth and they'll talk to us about the programs and what they're doing within the schools through the designated agencies, and we can go from there.
Yeah.
So yeah, great connection. So, Brian?
Hi. So before I ask you the question, I just want to disclose that I'm a clinical social worker and I have a private practice and I work as a part-time crisis clinician. So I'm often in the emergency room at I almost said Fletcher Allen, sorry, Medical Center. That shows you how long I've been doing it. But there are two questions I have for you that I could answer as a provider, but I think it's good people hear other providers' ideas. One is what are some of the ways that you're adapting care for the people who are stuck there to make it more therapeutic? And what are your thoughts about the integration of community care into the emergency rooms? Like as a private therapist, I can't go provide therapy to a client who's a youth, even though they're there 3 weeks. So they're getting no therapy for 3 weeks. And staff at our ED are doing things to make the experience more therapeutic for them. So I'm curious what you've been able to do and then what your thoughts are about going further and the integration of community care. And then I have a second question, but I wanted to give you a chance to answer that one first.
It's a great question. And for a long time, this is sort of what I was saying when I was there's no help coming. We're all there is. This is what we do. So, we would hunker down and I really started to try to build out programming for kids. I would develop therapeutic assignments, books for, children to complete. And, obviously part of it is sort of this, interstitium, this sort of place between where I would start to do med management and kind of work to try and stabilize people there. And we had some successes, but what I realized is that I want kids to be at school. I want kids to be in the community. I want kids to be kids. I don't really necessarily want to have the emergency department being a place where we start to mobilize all sorts of interventions, because it emphasizes that we're creating these half measures. We're not really creating a continuum that services and helps kids to really grow and have a different kind of future. It's really sort of saying the emergency department almost becomes a coping mechanism at a certain point in time. And I want to kind of steer away from that, because I originally thought, let's just keep doing things in the emergency department, but that it feels like I want to keep kids away from the emergency department after I've seen years and years of just the suffering that can happen. I feel at a certain point in time, we're at a threshold where harm happens to kids while they're just sort of waiting. We try to put curtains up, we try to prevent things, but there's still, we all probably have a concept of the emergency department. And I don't feel like that's a place where things could be optimal, I guess is what I would say. And I hopefully that answers some of the finer points of your question. Now, I will say that systems are siloed, and connectivity of care and continuum is very important. So I try to make it a point of talking to the outpatient if there is a psychiatrist, if there is a therapist. And I think your point there is absolutely very poignant, that we really need to have constant sort of care conferences. How can we make this better? How can we move someone from the emergency department back into the, sort of restorative work that we could do? And so I think we should reduce those silos by all means.
The second question was, what could be done to retain existing staff at this point, considering the really harsh working conditions that we have
Yeah.
to be in, because the state has dumped a bunch of money into like trying to recruit new people,
Right.
and it's not working.
Right.
And so at this point, if we're not able to get new people, I feel like we need to like try to save our existing
Yeah.
people before we lose them. And like, what do you think would help you and other staff like stick around while the state fixes the mess that we're in?
Yeah, it's a really great question, because you're right. Like, we can continue throwing a lot of money at travelers and things, and that's not necessarily going to be a sustainable model. So the thing that I find has been very helpful in retention is professional development. One thing that I have heard from nurses, in the work is I'm not a psychiatric nurse, Matt. Like, it's like we are, if you're serving the whole health, the holistic care of someone, you are a psychiatric provider. And so one of the things that I hear from that is that I'm not sure what to do here. I know what to do for a STEMI. I know what to do for diabetic ketoacidosis. I don't know what to do for kids in an emergency department that are experiencing psychiatric crisis. So I think a way to build that trauma resiliency and drop some of that moral distress down is really give people tools in the emergency department. And I think education can be a really strong factor for retaining folks. I do think there is an incentive. I mean, I personally have the gift of student loan debt. I know that that's something that's been very attractive for me moving to Vermont. I'll say like AHEC was a wonderful option for me, and I really appreciate what they've been able to give to me. And so that has really been a part of my personal experience of staying in Vermont. I mean, I also have a vision to make Vermont the best, psychiatric care in the country. So that's, it's mission driven too. So anything that sort of enhances mission, provides education, and, financially incentivizes folks, I think is another piece that might have been something that's already tried, but I do think there is some weight to that for our clinicians.
Matt, thank you. We have several more questions, but now that Dr. Strange is on, I'd
Yep.
like to make sure we hear from her. And
Of
I don't know,
course.
Matt, if you can stay, and then we'll open it up to questions. If
Yeah,
you
it'd be my
can't,
privilege.
totally understand.
I'll stay. Thank you for the opportunity. Yeah.
Great. Good morning, Dr. Strange. If you can introduce yourself to us, and then we're ready to hear from you.
All right, thank you. Good morning, and sorry to not be here at the beginning of the
No
session.
worries.
My name is Maya Strange. I'm a child adolescent psychiatrist, and I'm primarily based at the University of Vermont, where I wear a number of different hats. I'm the program director for the Child Adolescent Psychiatry Fellowship, the interim director for the Division of Child Adolescent Psychiatry, and I do outpatient work and some other and teaching here, and sometimes also do some per diem work at Central Vermont Medical Center, as well as at Champlain Valley Physicians Hospital in Plattsburgh.
Great. Welcome. Would you like to share your story?
Sure. So I have lived and worked here in Vermont for a little bit over 6 years. And so I've seen kind of the landscape of mental health. And these past few years in particular, I would say have been particularly challenging. And I think that there are a number of factors that go into this. Between the pandemic, financial pressures, just kind of the political climate and multiple factors, and families being under such tremendous stress. I think that all of those things combined and have really contributed to families being stressed. And in many ways, our youth end up being kind of the canaries in the coal mine, so to speak, with what may not only be happening for them and in the world that they are experiencing around them, but also even within their more immediate environments. And so while my primary clinical responsibilities are not in the emergency department for a number of different reasons, and sometimes because of the busyness, I've been called to help cover. And so it has been really challenging to see children and teenagers who are waiting for appropriate levels of care in the emergency department. And as Matt may have described, we try to put together things as best as we can and to make things as therapeutic and helpful, but it really does not replace kids being where they need to be. So oftentimes, if you were to see what this might look like going into an emergency department, these kids are often in a windowless room, a small space, sometimes the area has to be stripped down pretty significantly because there's often a lot of other medical equipment and other pieces that are just a part of being in the emergency department that are potential safety risks for the kids and the families. We may try to give them as much movement as we can, and if kids are safe enough, they might get to, take walks around the emergency department, but, they may not know whether it's day or night while they're there. We may try to put together different teams to be able to provide and use Child Life to provide some diversionary or leisure activities. But as Matt said, as I was coming on, they're pulled away from school, they're pulled away from many of their natural supports. And they're kind of sitting now in just kind of this limbo where they're stuck with their thoughts, which often were not in the best place anyway, that led them to being in the emergency department. And some families have described this as being traumatic. And for some families in particular who have not had exposure to mental health care, or this is their first time at this level of health care, it also can be quite frightening and off-putting, where then they are reluctant to seek the help that they may need later on out of fear of having to. It's a hard time for families, have a hard time seeing their children put through this, and children may have a hard time thinking about having to sit and wait for the care that they ultimately need. And there are challenges, I think, not just with inpatient, and some of this may be outside the scope of today, but some of the challenges are, I think, in looking at the continuum of services that are available. So I think that affects some of the children who we see who are in the inpatient unit that we have, that they may not be able to move on to another level of care without appropriate services being available. And while I think that there are many kids who are in the emergency department for whom inpatient is recommended, that's the appropriate next step. But there are also probably some for whom, if there were other resources available, that we might be able to also avert inpatient care. So I say that to say that it's not really an either or, but I think that looking at how we can address this need, because it's one that I see is continuing, if not potentially growing.
Thank you for that. I'm always struck, I think one other person who has testified in this committee in the past who made the same statement you did about a child or anyone in the boarding in the ED who doesn't know if it's night or day really strikes me as just incredibly, incredibly sad and inappropriate. So thank you for saying that again, because I think it helps to provide that grounding of, we can picture that in our heads now of the scenario you provided. So thank you, and thank you for your work in Vermont. So I think we'll open up for questions for either and see how this goes. And we have until a couple minutes before 11. It was Daisy, and then Joe, and then Alyssa.
Thank you both, and to your teams and everyone that gives so much and so much of their time and their families' time to make this happen. My question is around telehealth, and I believe we have new telehealth rules that allow intake or diagnosis to happen. Is that true? And I wonder if that gives us any hope for alleviating any bottleneck should there be open beds, which I know there most often are not because of your number 2 ask, the workforce. But can you talk a little bit about telehealth in terms of getting a diagnosis for some of these youth that are waiting?
Either one. Dr. Strange, would you like to start?
Right. I'm thinking about this, and I think I don't know that at least from my experience, I've not seen the presence or the absence of telehealth being one of the barriers in being able to access care. And I say this because when I do per diem work at Central Vermont Medical Center, for example, oftentimes the overnight shifts can be done by telehealth, and they've shifted to that during the pandemic. And I think that they've continued with that because with the notion that someone would be available to come on site if needed, but that we've been able to maintain a quality of care, and then also to maintain a staff to continue to be available to be on call for those shifts. And so the assessment piece and identifying the need for inpatient care has not really been where the barrier has been. We've been able to make those recommendations. And then the challenge has been finding appropriate care. And one piece that I also didn't mention is that with having currently one secure inpatient unit within the state of Vermont for those under the age of 18. There are also children or youth who can fall through gaps, particularly kids who may have co-occurring medical conditions without access to kind of imminent medical assessment or intervention. It can also be a challenge to place kids who, for example, may have a severe eating disorder, brittle diabetes, other neurological or other medical conditions that may have a risk for, significant decompensation that may require intervention.
Thank you.
Can I just ask a follow-up question to that, Dr. Strange, and or Matt? So those children who have co-occurring conditions, right? So they have a medical condition and are in a psychiatric crisis. And I just want to confirm, there are no places for those children other than within the hospitals today, which not many beds are available. So if there is a co-occurring condition, do they stay even longer in the ED?
My experience, oftentimes, yes. And then there is the challenge of determining, because in what I've seen sometimes is that a potential psychiatric unit may not feel comfortable or that's appropriate without the appropriate medical backup to accept a patient to their unit. Whereas a pediatric team may say, yes, they have they have an ongoing condition and it's serious, but there is not an acute reason to be medically admitted. And so then they're really stuck in this place where they're too medically acute to go to a psychiatric unit, not medically acute enough, or to need a medical admission. And then they really get stuck.
Thank you. Matt?
And I would simply add that is really the function of the emergency department for a lot of folks, both adult and kids, is this medical clearance piece. And so, if we could avoid that altogether, that would really, circumvent the hospital, being in the emergency department. But it does create quite a complication when there are, some medical needs when our sort of standalone beds, I think there's 30 that we can access, don't really have that pediatric team to support them from a medical standpoint. So it does create huge delays in care.
Great, thank you. Joe?
Yeah, first of all, I want to start by thanking you both because, it's so painful to hear what you're telling us. I can't imagine what it's like to live it on a day-to-day basis. And so thank you so much for that. Dr. Strange, you sort of began to answer my question, and perhaps what you said is all there is to say, but I still want to ask the question because I think that, we look at these numbers and we see there's these many people on average waiting 1 to 6 days, these many people waiting for a week. And I think one thing that I'm trying to wrap my head around a little bit is what that experience actually looks like for the person, for the child, for waking up in that windowless room and going to bed in that windowless room, brushing their teeth in the bathroom. I've been in the emergency room, car accidents and things like that. It's not a pleasant place to be. It's a necessary place to be, but not a pleasant place to be when you are in crisis, either for mental or physical health issues, a car accident. And so I just wonder, since Dr. Strange already began speaking to this, how do we get those stories out about the experience, of course, while respecting patient confidentiality and everything like that? Because I think those stories are so important to us all understanding why this is so important.
No, you're absolutely right. I think hearing some of those stories and to be able to and not just be about the numbers, but hearing about the people and the human aspect of it is so important. I think that there probably would be families who would be willing to share their experience just because they have been so disheartened by what they have encountered. But you're right, and thinking about patients who what they experience. And I have to say that not every emergency department in the state also has access to a child and adolescent psychiatrist and child adolescent mental health services while the youth are boarding in the emergency department waiting for appropriate care. So youth may be able to see a child adolescent psychiatrist and a social worker with a pediatric background and a psychologist while in the emergency department at UVM, but that's not universal across the state. So so they may be seeing a general psychiatrist who's checking in to see them and is seeing not just them, but all the adults who are in the emergency department as well. They are seen by the emergency department physician or provider who is also navigating many other medical emergencies and highly acute matters that are happening in the emergency department. And as Matt mentioned, there may be varying levels of comfort and knowledge around mental health, let alone pediatric mental health, with the nurses who are also interacting and with and working with the patients day to day. So these patients may be sitting there with possibly a tablet, or they may have a TV in their room that they may be able to access. Child Life may be able to bring them some items like some markers or crayons or some other things to color, but it really is limited. And some families, depending on their abilities, some families are able to have someone stay with them pretty consistently, but other families, because of either other commitments, other obligations, other limitations, may not be able to be in the emergency department. So the child could also be there by themselves with kind of a rotating staff, because there's also not a really good way, just the way emergency department shifts are set up, for there to necessarily be continuity in who is also providing care. So it can be different providers, every several hours with different shifts. Just to kind of illustrate a little bit more about what that experience might be like in the emergency department.
Thank you.
Thank you.
Matt, did you have anything to add on to that?
I would just say that is a really great point, sort of latently, about the impact it has on parents too. There was one story where the person had taken FMLA and they had run out because they were sort of addressing this crisis, and they had missed 20 days in the last 30 days of work, and they were no longer being paid because they were in the emergency department staying with their child.
Yeah. Thank you for that.
Yeah.
There's so many questions, so I'm sorry to say we're going to have Alyssa be the final question because we do have to move on.
So we've heard a lot of testimony the last 2 weeks from, disparate organizations, and like some of the things that are coming back to me, and I'm putting them into place, particularly Matt, with your 3 asks. And I just wondered, anecdotally, are you seeing the same people again and again? Or is the lack of aftercare, follow-up care leading to, this sort of, do you have a sense of repeat customers?
Dr. Strange, is it okay to me to field that one real quick, or do you want to? Okay, thank you so much. I would say that is part of the conversation, right? There are people that are just not being, even when they're, I think part of the thing that happens in inpatient hospitalization is it's difficult to find disposition in an aftercare plan when one doesn't really exist. And so it kind of makes throughput difficult. Like, it's hard to discharge someone. And so when you do discharge someone with kind of an okay plan, the plan doesn't necessarily have wraparound services that can help people. And so that crisis sort of builds back up and kind of goes back into the same process again. And then we kind of keep trying to figure it out and like limp along essentially. But I see a lot of that, yes. But I also am seeing new cases, new crises. This is not just people coming back because they're struggling. It's a yes and there's a lot of need.
Yeah, and I know that some of the quality measures for the ACO have a lot to do with follow-up care, within 30 days of ED mental health visits, follow-up care within 7 days of inpatient. I'm wondering if you're seeing, because you had talked about more resources for that follow-up care. I'm wondering if you're seeing things getting worse?
I
this
do get a
regard?
sense. I do get sort of an accumulative sense that things are accelerating to a worse place. I would say that absolutely is what's been happening in at least the last 2 years.
Okay, thanks so much. And thank you for everything that you do.
So I think I speak for all of us when I say, again, thank you for your service to Vermonters and caring for some of our most vulnerable. Also, please express our gratitude to your colleagues as you see them. And we will do everything we can to get you the resources you need to ensure that you all stay safe and healthy, but Vermonters do as well. So thank you both for your time. We appreciate it.
Thank you.
Thank you. And thank you, Dr. Strange. Thank you.
Thank you all. Thank you for this work.
Have a great day.
Thank you too.
So we are going to not dramatically, because everyone needs help, but we're going to change our focus a little bit and have Jill Olson join us. We have not met Jill yet, so we'll do some introductions, but this is a request from the Visiting Nurses Associations who would like to add something to the BAA. So this proposal in front of us was not offered by the administration in the BAA, and it will be our decision once we hear and talk on Tuesday whether or not we should recommend to the House Appropriations Committee that this request be added. So, Jill, I'm going to introduce everyone. I don't think you've been with us.
No, I have not. Thank you.
You know, we're going to really shake it up a little bit. We're going to start with Brian.
We've met.
Not doing all that.
We've met before, but I'm Brian Chena from Burlington.
Thank you.
Go that way.
Alan DeMar from Enosburg, Montgomery.
Hi.
I'm Joe Andriano. I'm from Orwell. I also represent Shoreham, Glen, Sudbury, and Hubbardton.
I'm Bobby Farley-Strubio from Caledonia 1, which is Barnet, Reigate, and Waterford.
Okay.
Mark Peterson, Rutland 1, which is Clarendon, Wallingford, West Rutland, or part of Rutland Town.
Leslie Goldman, hi. Good to see you again. Wyndham 3, Rockingham, Westminster, and Brookline, and that's the Bells Falls area.
Representative Rebecca.
Mari from Lincoln.
Yes, you, I know.
Francis Matthew James.
Okay. Wow. Okay.
And Lori from Essex Junction.
And Alyssa from Northern Essex.
Great.
Wonderful. Thank you so much. So I was also going to take a little bit of time to sort of do my intro to home health before I jump into my ask, just to give you all a sense of who we are. And actually, I would say, especially for those of you who are new to the legislature, if you've never done a ride along with your home health agency in your community, I strongly urge you to do that. I think many of them are doing those again. And it's the people we serve generally don't leave their houses a lot, or when they are, especially when they're sick, they're not, they have to be homebound to get our services. It's really hard to see in action what's happening for home health, but many agencies have made that an opportunity for their legislators, and I really, really urge you to do it. You can't believe what's going on out there until you see it. So I'm Jill Olson. I'm the executive director of the VNAs of Vermont. So we represent home health and hospice. And one of the things that I think is a little confusing about representing home health and hospice in this building, especially in the House, is that we do healthcare and we do social services. And so sometimes I'm here and sometimes I guess it's over there now, over there. So because we have different kinds of services. And what I've discovered since I've been doing this job for about 6 years, and before that I was with the Hospital Association for a long time. Often people either know nothing about what home health agencies do, or they know one piece and then don't know about all the things that we do. So I always like to sort of do a little bit of who we are, what do we do, just to keep everybody oriented. So this is kind of my big list, our big buckets. So I think it's really important to know that we do healthcare. We actually do some pretty complicated healthcare, but we do it at home. And so we do a lot of wound care. We do a lot of care for people right after they've had surgery. We do therapy in the home for people who have had joint replacements. We do intravenous antibiotics. So reasons that you might need a nurse coming into your house or a therapist coming into your house. And absent this work,
we would have many more people stuck in the hospital. So this is the work that we do, generally speaking, that is taking people out of the hospital and getting them home. It's critical to that process as well. And people really like to heal in their homes. So people are, if someone can go to straight home instead of through a rehab facility, for many people, that's their preference. We also do, and I just have to say, we did a lot of COVID care during COVID in people's homes. Imagine getting into your PPE in the driveway. PPE, personal protective equipment. So your mask, your gown, everything, but in the driveway.
In the winter.
In the winter.
Over and over again.
And no visitor policies in home health, right? Anybody could be there with their barking dogs and, anybody can be there. So it's something that I think nurses who do home health have a very high degree of autonomy and have to have a tremendous amount of critical thinking skills because they're all by themselves down any dirt road, anywhere in this state. They walk in the door. So I just think it's really something to consider when you're thinking about home health, what that might feel like to open a new door. Lots of prevention work, health screenings, foot clinics, vaccinations. We did a lot of at-home vaccinations at the beginning when we were really first trying to get everybody vaccinated. And then lots of maternal child health, both programs that just sort of help people prepare to be parents and then go through the first year and a half of the new baby's life. And then we do long-term care. We generally talk about long-term care over here. And so that is really, so that's not healthcare. That's assistance with the things that people need help with in order to stay independent. Bathing, incontinence assistance, dressing, nutrition. So many people could not stay independent in their homes without help. I mean, we probably all know people like that. I certainly have, a few in my life. So it's really critical care. So that's what personal care is, homemaker, all of that. It's mostly provided under a program called Choices for Care, which is Vermont's long-term care Medicaid waiver. So to be on a long-term care Medicaid waiver, you have to both have the financial qualifications for Medicaid and the clinical need for a nursing home. So everyone we take care of on that program is clinically appropriate for a nursing home. And if we're taking care of them at home, they're not taking up a bed in a nursing home. So when you think about a home health agency, pretty much everyone we touch is someone who, if we weren't there, would be in a hospital or in a nursing home. Almost everybody. So that's, when I think about our role in the system, I think that's something that's really important to remember. And then we do hospice services, end-of-life care. And so what I always say about hospice is that it's a service, not a place. So sometimes people think it's like there is an inpatient hospice in Vermont, but you can get hospice care in the hospital, you can get hospice care in a long-term care facility, you can get hospice care at home. So there's lots of places to get hospice. Hospice is a wonderful service, multidisciplinary. There is support for families, there are social workers, there's clergy, there's medical help for the person, for pain management, there's goal setting. It's all of healthcare should actually look like hospice. Really, all of healthcare should look like hospice, where all of that is wrapped around. So that's sort of the breadth of our services. So let me just pause there. I only have a few slides, but so let me just pause on that one. See if people have any just general questions about who we are, how we're structured.
Well, this is a personal story. As someone who had a really traumatic fracture in my leg, and surgery and the works, your nurses came to my house, your physical therapist came to my house, and you taught me how to walk. And I so appreciated that. I still have visions of it and I'm getting tearful. It was big. And now I can walk and so your services are crucial on so many levels.
Thank you for saying that. I will take that back because I have members working pretty hard out there.
Oh, you're absolutely true.
Yeah, thank you.
Anyone else have any questions? Daisy?
I just want to be sure I understand the table correctly. So you do serve adults and youth and children?
Oh, yeah.
Okay.
Oh, yeah, everybody. Yeah, especially in the high-tech program is really for people who need like ventilators and other kinds of services. That's a really hard program to staff. It's always in crisis. Yeah.
And I Alan?
Okay, I've had some experience with elderly aunts. Some of the staff, voluntary staff that just help out.
On hospice, yes, there are volunteers. Yes, there are hospice volunteers. And we didn't have them for a long time during the acute phase of the pandemic, but they're back.
And I just want to also bring in, I don't know if everyone's heard the news, but we do have a nursing home that is closing in
Northeast Kingdom.
Another one. And, so as Jill says, these services are vital to help keep people in their homes, because we don't, nor do they most likely want to go to a facility, but we're losing the beds.
That's right. And just to be clear, those facilities are critical to the continuum. We absolutely need them. They're really, really important.
Both are, yes.
Yeah. Okay, so just a few things to know about us. So there's 10 home health and hospice agencies in Vermont. So there are 9 that are geographically located. So if you go to the website of the VNAs of Vermont, you can plug in your town and you can figure out which agency is yours. And then there is Viata, which has a statewide certificate of need and covers services around the state. They are actually not one of our members, but on matters of policy, I really try to stay aligned with them. And really the issues are mostly trying to deliver care in the home is kind of the same no matter what your structure is. We are an entirely not-for-profit system. So we are structured very differently than most states. In most places, there's a lot of for-profit home health, there's for-profit hospice. And so one of the things that we're challenged by in Vermont is that the federal policy matters a lot to us. It's not built for us. So it changes our world, but it's not built for a place like Vermont.
Because most of the other states have a
different
for-profit and not a nonprofit.
Right, and they don't have a designated system where you're covering geographic territory so there's a lot of differences because we will take all individuals regardless of ability to pay. And what's stopping us from doing that now is really workforce. Yeah. So 1 million visits a year or so. Some of these numbers I'm updating now because we were sort of waiting to get past the acute phase of the pandemic and for the data to catch up so we could see where is it now. So some of this may change. But this is about right. 1 million visits a year, 6 million miles of driving that we pay for, but that we are not reimbursed for directly. So when gas gets expensive and the IRS rate goes up, matters to us a lot. Big issue for us. I think the average daily census now, which means how many people are being taken care of every day, about 7,000. So many more people than say are overnight in a hospital on any given day. About 2,500 employees, small amount of the healthcare spend, about 2% of expenditures. And then this is the most recent payer mix. We call it the payer mix I was able to get. So we are mostly Medicare, right? We are mostly Medicare. That's why federal policy matters so much. So the primary payer for our services is not controlled in this building. It's controlled by the federal government. And this is something I've never said before because it's starting to be an issue. In that other category, that's Medicare Advantage, and they are killing us.
Well, how? What do you mean?
Because their rates are horrific. So some are great. There are many that are paying us episodic, sort of similar to Medicare. Many are doing that. The largest one is not. It's paying worse than Medicaid. And won't negotiate. We have sort of an organization that's job is to negotiate on behalf of home health agencies. They won't negotiate with our negotiator, and they would like to have every individual agency negotiate for themselves. Big national company.
Art and then Alyssa.
Jill, I just want to understand what you just said.
Yeah.
So you're doing the work at $100. They're paying you 50.
That's the idea. That's the concept. Yes, it's not exactly those numbers, but yes, that's the idea. Yes.
So that's what's happening with Medicare Advantage.
Right. Medicare Advantage is they are paying so let me just be clear. Some plans are paying fine. They're matching Medicare, but the largest one that we're dealing with right now is paying very poorly.
And
there's more of and their penetration is increasing. So when I started this job, we didn't talk about Medicare Advantage. It was kind of a non-issue.
And that's the policy that the person you're serving
has chosen to right.
Okay, so you're getting, and excuse my lack of understanding here, but these things are the person you're serving the elderly usually, I would think,
Usually,
have those plans, and that's where the reimbursement comes in.
that's right.
Thank you.
You got it.
Lisa? I just, I mean, I know that the Advantage plans under Part B are required to pay Medicare rates. Are they not required under this?
They're not required to pay us the same rate, no.
That is disturbing and shocking.
Yeah. Yeah,
Sorry.
yeah,
Very much so.
yeah.
But we have no leverage.
That's the challenge. No leverage.
We have no leverage.
Maury?
On that issue, do you have any information about what the federal delegation might be doing about it?
I don't, but I have been in touch with them about it. So yeah, I made that call last week to start that conversation about how to get some help.
So we could reach out to them as well.
Please. Yes, I welcome that.
Leslie? So instead of reaching out as individuals, could we write a committee?
We can talk about that later.
Great.
Okay, I'm gonna keep going. Let's see the time. I don't have tons of slides, I promise. Yeah. Pressures. So many. So here's the first one, travelers. So we are really struggling to actually serve everyone who needs long-term care services. So you'll hear a lot about that we really don't have enough staff for people who need that care at home to stay independent. But on the skilled side, on the hospital discharge side, we've managed for the most part to preserve access. A lot of it with traveling nurses. Not keep going like this. $300 a visit for a traveler, $154 for Medicare on a per visit basis. There's another payment model that's a little bit better than that. $122 for Medicaid.
So there your numbers are, to your cost.
Yeah.
So some agencies are using a lot of travelers, some agencies are using none. Some are sending their CEO and senior staff out on visits in order to avoid travelers, but fill the gap. Okay? That's the same agency that the CEO vaccinated 700 people in her community and made her face shields at her kitchen table. She is a very resourceful human being. Yeah, well, it was quite something.
Jill, can I ask you to do something? Can you go back to the first slide?
This one?
So you use skilled nursing.
Yeah, that's healthcare, yes.
I want to just, yes.
Yeah.
So healthcare would be the skilled nursing.
Yes.
piece, And then that's what we're talking about in this segment. Okay.
Right. And that is really in this committee, and it's a DVUB budget issue.
Yep, go ahead, Jill.
I just noticed on the pressures slide that the bullet points is critical for timely hospital discharge, and that made me think of something I saw yesterday. So I went to the Agency of Human Services presentation that they did over in the pavilion, and one of the slides they showed us was entitled "Number of Individuals Waiting in Hospitals Who Need Long-Term Care or Home Health Services."
Yeah.
And since basically the beginning of June, the lowest we've seen in that is 112 people waiting in the hospital. The highest was at around 158.
Mm-hmm.
And then they said that sort of part of the pipeline problem is that if you have people stuck in the hospital because they can't get the home health care services, then that when we're talking about admissions, I mean, that bed can't be admitted because they're taking care of those. So how would this, if at all, the budget adjustment that you're asking for help alleviate that bottleneck?
I actually need to take a step back because most of the people who are having trouble getting discharged from hospitals are having trouble getting to a facility, not to home health, is my understanding. So I've been trying to make sense of this. So I would say we are about to become part of that problem, but for the most part, and I've actually talked to the UVM Health Network just to understand this better. It sounds to me like they are having trouble with discharges to New York, and which is not our agencies, and but not so much discharges in Vermont. And in fact, what some of my members are seeing is that they're not getting referrals because there's a perception that we aren't able to take the patients for the skilled referrals, but we still can. So I would say this is something we're trying to preserve, not fix. So I think that's I would say that we are not a big piece of the people who are waiting in hospitals, is my understanding. So, but I don't have the data.
Right.
Personally.
And to your point, it could become part of the problem.
Yes. Yeah. So this is something members are really, actually, my agencies are very sensitive about because of this referral pattern thing that they're starting to see where they're not getting referrals they think they should get. So, yeah.
Hypothetically, do you think that there's a danger or a risk of patients being discharged from the hospital that really need skilled nursing facility or subacute rehab are having to bypass that and go home with home health support that.
I guess I would say I don't know that I can speak to that for myself. I don't feel like I have sort of like the knowledge base for that. It's certainly plausible. I see why you're asking the question, but I don't know. I mean, certainly I would say every part of the healthcare system is more acute than it used to be, right? So everything is more at every level, every type of provider is doing more than they were 10 years ago and taking care of people with more complex needs than 10 years ago. And part of it is that because people also are living with much more complex conditions than used to be survivable. That's part of it.
Right.
Tucker.
I'd like to go to the comment about referrals.
Yes, sir.
Not getting them. Who's getting them? They're going somewhere.
They might not be going to the local agency. They might be also going to BIATA instead of the local agency, and both should be a choice for everybody. Or it might actually be that that they're getting referred to more. There's more effort being made on the skilled nursing facility side instead of on the home health side. So it's just a perception question that we're trying to sort out. We just want to make sure they are coming to the agencies, to all agencies, if they can. Yeah. Okay, so travelers, big issue. And agencies are really struggling to figure out how to keep access and not pay for so many travelers because this is just not workable. So it's been a big year, really tough year. A lot, agencies have spent down reserves. This is a limit to how long they can do that. Wages, salaries, and benefits, all of that is under tremendous pressure. So when you hear that a large hospital raised their wages for nurses, that is great, and also an issue for any other provider in the system. We are losing nurses to other providers, and it's just a fact. Everybody is trying, because all providers in the system are doing the best they can to take care of the people they're supposed to take care of, right? So everybody's trying to do their best job in their part of the system. And benefits are bananas. The health insurance rate increases hit at a really tough time, and they were really big, double digit. And then the IRS reimbursement, so it went from 58 cents this time last year. It's now 65. 6 million miles of that. So big number. Yeah, it's really, for most providers, like the IRS reimbursement is actually a small thing, but for us, it's very big. We have a provider tax. You will always hear me complain about this. So a provider, this is a whole complicated area of policy. I will not deep down the rabbit hole on this, and I promise you I'm talking to the Ways and Means Committee about this. But essentially, the way things work, the states are able to tax classes of providers and then draw down the federal Medicaid match on the tax revenue that they collect from the provider. So that's why we do it, to collect the federal revenue. But for us, just feels like a cost. It's just a bill we pay. And it's right now at $6.1 million in this fiscal year.
How much?
6.1 million statewide. Yep. Migration to Medicare Advantage, we've already talked about. And then this is all coupled with Medicaid, low reimbursement, inconsistent rate increases. So the tax, what I always say is the tax is forever. It's in statute. We always get the tax. Rate increases are intermittent and don't necessarily reflect our true costs. Then, on top of all of this, Medicare has decided to cut our base standard rate.
Cut?
Cuts. Yes, correct. You heard me right. Cut. They cut us on January 1st. So Medicare has been trying for probably 15 years to squeeze out our surplus. They do not want home health agencies to make money on Medicare. That will be fine, except that we are subsidizing Medicaid, and we have for a long time. So the only reason this house of cards on long-term care, on skill, any Medicaid service that doesn't pay, you can only be a provider who does something at a loss if you're doing something else at a gain. It's the only way. There is no other way. And if I go way back to my payer mix slide, we're pretty much paid by the government, Medicare or Medicaid. It's almost all there is. There's a little bit of commercial business. So we have no control over how much we get paid, and the payers are not especially responsive to the changes in our environment. So they don't pay us more when gas prices go up. They don't pay us more when the traveler costs go bananas. They just don't. Or they might do a little, but they certainly don't respond fast. So we got a 3.925 cut on January 1, only because we made a lot of noise about the full cut, which is the 7.85 that will happen on January 1 of next year. The only thing that can stop that cut from happening is Congress. Have you heard of Congress? Okay, so it's a very scary situation. So that is, again, to the base Medicare. It's called a standard rate. We have a good payment. We have a better payer payment Medicare, which is it's episodic. It's called PGM. 1,000 acronyms. This is the one they're cutting. There's also a fee for service fee schedule, which is relevant for our Medicaid. That one actually went up a bit. And then they're planning a 3-year clawback. So they want to go back to 2020, clawback 7.85 per year, going back to 2020, because they think we've been overpaid since they changed the payment system.
Okay. 1 second, we have a couple questions. Daisy?
Part of Choices for Care, yes?
Nope, none of this is Choices for Care. This is all skilled. This is all healthcare at home. Choices for Care is a state program. It's a Medicaid program. So there's a federal match, but the state is in control of that program. They set the rates and they draw down a reimbursement, but it's not set by the federal government. This is all the Medicare is all of our healthcare at home. There's also hospice piece, but the cut is to our healthcare, is to our skilled services.
So this sits outside of our 1115 waiver?
Oh, yeah. Yep. That's right. It's totally separate.
Art?
Just to follow up on what Daisy just asked, so, and back to the first slide, so it's the healthcare piece
That's
that
right.
we're talking about.
That's right.
The other folks, the other care is done by folks without that expertise, I assume.
That's right. It's not professional services.
Okay, so
Right.
this is
You don't need a license to do personal care. This is our skilled services.
Okay.
Skilled meaning you need a license.
Gotcha.
Yeah,
Thank
this is our medical care at home. We also have a hospice payment schedule. That's also under
That's
pressure.
all in it.
But the cut is to our
Gotcha.
health care at home.
Thank you.
The services that you received is what we're talking about.
Okay, so I want to make sure we get to the ask.
We're going to. This is my last pressure. I think it's my last pressure. So this is our request. We are requesting in the BAA $422,000 of state revenue. What we are trying to, and it's about 1.1 million with the gross for the federal match. We are trying to get to 90% of the fee-for-service Medicare schedule. So remember I said there was a bad one and a better one? This is the bad one. We're trying to get to 90% of the bad one, not even considering the fact that we pay a provider tax. So primary care is at 100% of Medicare. We've really tried to do that over a long period of time. And in 2019, I said to Diva, we really should be doing that for home health too. We really should be paying at Medicare too. And so we've gone through this process for a number of years to try to get there. Part of that process was they moved our date of rate schedule updates to January 1. That's why this is a BAA request. Our last increase was 1 year ago, January of 2022. So they moved us on purpose, and we had some lengthy time between rate increases while they moved us to get to January 1. So we're on January 1 because we were moved to January 1. We were expecting to see more progress toward getting closer to Medicare this year, and we did not. So we were surprised and concerned to not see that we'd made any more progress. So that is why we're asking for it at this moment. That's why it's not a budget request, it's a BAA request. So I just want to make sure that that's clear why the timing.
Joe?
This progress that you're talking about, who's that in negotiation?
It's with DIVA.
With DIVA?
Yeah, with
Okay.
Medicaid, yeah.
Thank you.
Yeah, so they, and they obviously, and I'm sure you've heard from them, they have their own pressures, they have high caseload pressures, everybody's under pressure. So, I absolutely get that, but yes, that's been a process we've been trying to get better along with them.
So I just want to clarify, this is a request for one-time funding to bridge the gap or an ongoing?
This is a rate increase. This would bring our rate to 90% of Medicare. Yeah, the one-time funding is helpful, but it is not going to get us to a place where we can sustain these services over a long period of time.
Anyone else have any questions? Leslie?
I'm really trying to articulate it so someone might help me. We're talking about renegotiating with the federal government in our new agreement.
They all pay, you're talking about the all-payer model.
Yeah, as we look at that, are home health services involved in that discussion?
So the discussion with the all-payer model is at the Agency of Human Services level. So we will have to ask them that question.
Okay.
Yeah, we've been in all of the discussions, but it's not likely to change our payment. It might, the main thing it would do would be to expand it's a pretty narrow criteria for who we can serve. And probably the primary impact would be letting us serve more people if we had the workforce to do it, who don't meet all the narrow criteria Medicare places on us now.
May I follow up? Sure. So is that something you're interested in pursuing?
Oh, absolutely, yeah. No, and we're part of that conversation.
Okay.
Yeah.
Just to put the magnitude of the problem in the proper perspective. 100% of all the home health agencies, are they losing money?
Yeah, I believe it may, I don't know about Biata because they're not my member, but and I'm just collecting data from all of my members. It's either all or most. Yeah, if there are any that aren't, it's one or two. And once we hit this 7.85 cut next year, there's no way anybody will be.
I didn't realize there was even one or two.
I'm not sure there is. I literally am finishing up examining all the data and I don't have information on one agency.
The loss is substantial.
For some, the losses are really big. That's a range for sure. Largely dependent on how much travel they're using.
Right.
Yeah.
And this is a service, at least in my opinion, that the state of Vermont can't afford to lose.
That's right. That's right. I don't think we can put any more pressure on hospital discharges, which is what the loss of these services does.
Daisy?
Are most of the folks you serve dually eligible?
No. Choices for Care, many are dually eligible, but in the Medicare, no, it's anybody who's over 65 in Vermont. So is eligible for Medicare. So yeah, no. People who need skilled care need it for all kinds of reasons. Anybody who needs surgery, hip replacement, all that.
All ages.
Yeah, all ages too, but Medicare is 65 and over. And we're mostly Medicare.
If I can just make another statement. Yeah. On top of that, there's a ripple effect because they're keeping people out of the hospital. And if they're not around, the problem you have in the hospitals now is going to increase.
That's right, because we're also reducing readmissions. We also get community referrals and prevent people from going to the hospital in the first. All of that is true, absolutely. No, I think home health is an inexpensive and critical part of the system. That's how I feel about it, and I really urge you to support it.
One last question.
Okay, and this is more of a personal question than anything because as someone that's over 65, I get calls, my wife and I, to have someone come in and do a check at your home. Is that part of the system?
You mean like random calls?
Well, no, we twice.
Can we talk about fraud and scams? No, now you're making me nervous.
No. I hope it wasn't. It was pretty, both times the folks were very good. Yeah. But they would come in and take your blood pressure, ask you a lot of questions, and just do a home health check.
I don't know what that, I would want to, I mean, if you need home health services and you qualify for them, you get a 2-hour assessment. I call it the adult child of the older parent assessment. It's called OASIS, but that's what it is. It's a safety check, a med check. Yeah, but I'm not, we have to talk more.
Okay, all right.
Yeah.
Totally different thing. Yeah. Okay.
So the rest of her presentation has more facts and data.
It's BAA. It's what we submitted across the.
Yep. So please.
Down the stairs now to the appropriations.
So please review. And like I said, we'll talk about this Tuesday when we have our committee discussion around BAA. So one, thank you, Jill. And the same thing I said to our last people who were in here, please express our gratitude to everyone who is doing this hard work.
I will. Thank you. Thank you for making the time. And I don't know, Claire's actually over there. She made it happen.
Yes.
So thank you.
All right, we're going to move on. Our last piece for the day, or for this morning, is another budget adjustment request. Again, this was not in the proposal that came over from the administration, but it also has to do with Medicaid and Medicaid reimbursement rates. And I think, is Jim joining us online? Okay, please let him in. We're going to go right to it, and then we'll break for lunch. Can it wait?
Process question.
Can it wait? Yeah. Good morning, Jim. Welcome.
Good morning. Thank you.
Thank you for joining us. I believe this was a bit short notice, so we appreciate your time. I haven't looked. Did you send us a presentation, or will you just be talking to us?
I'll just be talking if that's all right.
Okay, great.
Really send any follow-up information as needed.
Okay, great. So if you can introduce yourself for the record, and then just know, I have not given everyone a whole lot of preview on this, so because we haven't had time. So take us from the beginning through what you do and your request and why it's needed.
Great. Thank you so much. All right. So thank you both, Madam Chair, and the committee members. For the record, my name is Jim Moulton, Moulton. I am the Executive Director of Tri-Valley Transit. We are headquartered in Middlebury, but cover the geographic middle third of the state from, as I like to say, the banks of the Connecticut River to the shores of Lake Champlain.
Not so lovely.
Kind of gives it a very nice Vermonty feel, you know?
Exactly.
And I'm also the chair of the Vermont Public Transportation Association, which is the trade group that encompasses all of the transit providers around the state. And so that's one of my roles, and that's the primary role that I'm here today on, is to speak in that vein as the chair of the association. We do provide public transportation for the general public, for elders, persons with disabilities, Medicaid members, and many other members, in smaller groups, let's just say. We provide access to jobs, we provide access to healthcare, access to shopping, legal services, kind of everything. Sometimes I've heard it described that we may not be the direct provider of services that people need, but we are the connective tissue to get people there. Today, I'm here specifically to discuss a funding gap in Medicaid transportation. This funding gap does not appear in the governor's budget adjustment request. You've probably heard a lot of testimony from other groups already about a lot of the financial challenges that they are facing. Obviously we are affected by many of those same things: general inflation, labor market shortages, et cetera, et cetera. We also have obviously a couple of very specific things to transportation, fuel prices being the biggest by far. And then the other, which is related to that, is you may or may not be aware that a large portion of the work that we do is done with a volunteer driver workforce. We recruit volunteers who give their time, but we reimburse them mileage for the cost of using their vehicles, so that we're covering their fuel, insurance, tires, maintenance, et cetera, like that. And we use the GSA rate and the IRS rate, federal rates, to provide that reimbursement. And those costs have also gone up significantly over the past few years. One thing that's unique to the issue that we're facing in Medicaid transportation, the way that it's funded, it's very similar to an insurance plan, in the sense that you have the members who are receiving our services, and they are having effectively premiums paid into our system that then encompass a pile of money that we then use to deliver the services. You have some of those members. Some of those members may use the services very little. They may be in relatively good health. They don't need to see the doctor very often, don't need emergency service. And then we have all the way to a group that we call either critical care, or super users. These are folks that are using our services, on a very regular basis. Kidney dialysis 3 times a week. Cancer treatment can be every day for a couple months, 3 months at a time. Treatment with methadone for those in rehab is daily. So there are a lot of people in our system who are using those services on a frequent basis. And as I said, we call them super users. Since 2020, we have experienced a 20% drop in the number of members utilizing the Medicaid transportation system that are paying into it. So the system, again, is set up on basically a premium basis. We get a certain amount of money each week for everybody who's in the system. If they don't happen to use the services, then they can drop out of the system, and that dropout can happen at any time. But a 20% drop in revenue effectively. At the same time, we've seen a 50% increase in the average number of rides from each member. So, and that is based heavily on the super user effect. COVID had a lot of negative health impacts for people. And so we've seen a lot more folks on the behavioral health spectrum that we are providing these 7-day-a-week services for. Another element about the Medicaid transportation system and us as public transportation providers, unlike, say, a hospital, we are unable to cost shift. So if we incur a loss in our Medicaid services, we incur a loss in our Medicaid services. We cannot use our public transportation grants to offset that. The public transportation grants that come from the federal government and filter down through the state, they are effectively cost reimbursement only. So when we have costs, we submit those expenses, we're reimbursed for those expenses. Those also require, you may be familiar from other conversations, local match funds, which we fundraise for in various ways. Those are typically 80-20. So the grants cover 80% of the public transportation costs, and then the 20% local match draws those grants down. But we don't have a private insurance company that we can cost shift those Medicaid expenses onto. The impact of those major elements that I just talked about, the drop in revenues and the increase in super users, has created for this fiscal year, FY23, a $1.7 million projected deficit. We've actually incurred half of those as real losses during the first 6 months between July and December. And so we are seeking additional funds through the Budget Adjustment Act to offset that so that the program effectively breaks even. So I'm happy to take any more questions or provide more background.
Great, thank you. So we have a couple questions, Jim. I just want to clarify to make sure I'm understanding this correctly. So you provide rides for critical care needs, all sorts of needs, and you're paid by Medicaid, and you're paid a per member per week.
Correct.
Payment. So if you have 10 members, you get paid per week for those 10 members.
Correct.
But what you're saying is that has dropped down, and excuse my fake numbers I'm using, down to 5 members per week. So now you're only getting paid for those 5 members, but your actual rides that are requested has increased maybe 20%, and you're not getting paid for that increase because you're just getting that one payment per member for those 5. Does that summarize it well?
Yeah. So to take your example a little further, so, going from 10 down to 5, we now have, from that, let's say 10 down to 8, because it really has been a 20% reduction in revenue. So from 10 down to 8. And if prior to the pandemic, we were seeing, let's say, 1 ride per week per member, we're now seeing 1.5 rides, a 50% increase. So we've gone from providing 10 rides to 10 paying members. Now we've got 8 paying members, but there's 12 rides that we're providing. So we're providing more rides than before, 12 versus 10, with less revenue, 8 members instead of 10 members. So the push in both of those directions has created this gap in funding.
Great, thank you for that clarification.
You're welcome.
Maureen?
Thank you, Jim, and thank you for this incredibly important service that you provide. I want to, with your help, focus on the people that are receiving this service.
Sure.
What happens for them when your capacity is stretched or you don't have the resources? And some of this information are anecdotes and actual numbers from the Office of the Health Advocate, where people, the transportation, and I would like you to corroborate this or speak to it more. Their transportation might be late, so they miss their doctor's appointment because they weren't able to get a ride when they thought. And then there was something about a communication challenge between the authorization of the ride, so on the state side, to when it gets to whoever is a dispatcher, saying, yes, this ride has been authorized and this person should be picked up at such and such a time. So can you speak to that a little bit about capacity issues and the communication between authorization of the ride and when it gets scheduled?
Yes, absolutely. So I may bounce around a little bit because you covered several elements that may, on the one hand, be unique to one particular person or ride, but actually are throughout the system. So Medicaid, of course, is an entitlement program. So we start from the premise that we're providing every ride that's requested. That is the mission, that is the goal, and that's really baked into everyone's DNA. That's our, we're looking to do that. We're not looking to deny rides. Capacity is absolutely an issue. Pre-pandemic, we had roughly between 500 and 600 volunteer drivers around the state. Not that they are the only ones providing Medicaid transportation, but it's a very large percentage of those trips. Now, coming out of COVID, we are at half that capacity for a lot of different reasons, but that has placed a lot of burden on the remaining volunteers. It has increased the stress levels on the dispatchers who are trying to arrange these rides. When your capacity in that way is cut in half, you are constantly scrambling, spending a lot more time trying to get those rides arranged, match them up. It provides less time for those other details sometimes around like the authorizations. There are limits sometimes on what we can do. For example, if a member has a vehicle in the household, we have to get proof from them that they cannot use the vehicle to get to their Medicaid transportation before we can provide that ride. So that could be a couple of different things. It could be that, we've had people who say the vehicle is broken. It just sits there. They have to get certification from a mechanic that the vehicle doesn't operate before we can provide the ride. It could also be that there's another member of the household who uses that vehicle to go to and from work. We would have to get a statement from that other family member's employer stating that that employee needs that. So those things can take time. And as I mentioned, briefly, and again, everyone else has experienced this, but labor shortage has also played into that. We have fewer dispatchers available to do all of that kind of work. So we have got dispatchers who, through this process, have been placed at a more stressful situation. There are fewer of them to do the volume of work, and there's more of this work to do. So sometimes that communication process can get slowed down. There are times when we just don't have enough either volunteer drivers to do everything. And we have started to shift onto more cost-expensive modes in order to meet more of the actual demands and not create those situations that you described where someone misses their appointment. But it's much more expensive to put people onto a lift-equipped vehicle with a paid CDL driver than it is to put them in a passenger car where they're getting mileage reimbursement only and there's volunteer time, there's no wage. So that has also pushed up the cost of delivering services. Again, in this kind of rock and a hard place of we've got to provide the ride, not only because the person needs it, but it's an entitlement program. And at the same time, we've got fewer resources to do it with. So the pressures become really high. And I can give you one additional example, which is that we recently had a member who needed dialysis service, still needs dialysis service, but had tested COVID positive. At the height of the pandemic, a lot of the ambulance companies around the state were providing transportation for COVID positive folks who had to, continue to get their dialysis, but were in that situation. The ambulance providers around the state have been burnt out, are short-staffed, are unable often now to do it, and certainly unable to do it on short notice. Our executive director, who is the central point of contact for Medicaid transportation around the state, she and I were on the phone for a day. She was spending most of that time contacting every ambulance service that she could find in the area, trying to find somebody who could provide this COVID positive transportation. No one was able to, working with the dialysis unit to see what was possible. Eventually, they made a medical determination that the person could wait until their next, so rather than getting the ride on Monday, having to wait until Wednesday to get the ride, in which moment, with that notice, the ambulance service could provide it. But of course, that's a very, very, very expensive way to provide transportation. So that's sort of an overview of the types of things that come into play when we are trying to provide the transportation, the sort of hurdles that we have to go over, that the riders themselves have to go over, and the challenges that the resources have made for us. We have worked, and I say we, both Tri-Valley Transit and around the state, to overcome some of our labor shortages by changing our compensation packages to make our jobs, have a livable wage for the folks who are doing this, and to, be able to be there every day. So I'll stop there and give you.
Thank you. That was very helpful.
Thank you. Anyone else have any questions? No. I will say Adam Lawrence did provide written testimony as well. And so you can find that under today's date, which will reiterate a lot of what Jim has provided us here. So again, this will be on our discussion plate for Tuesday when we talk about BAA. So Jim, thank you. Sorry, there was a question.
No, the question is, I'm looking at the written testimony right now. What exactly is the ask? Because I couldn't find it.
Jim, can you remind us, and I do have that somewhere in writing, which I will send to everyone, but can you remind us what the ask?
Yeah, so we are projecting right now, based on the first 6 months of the year, a $1.7 million deficit for the full 12-month period of fiscal year 23. And that's statewide. That's Tri-Valley Transit, SSTA, GMT, all the providers put together. The contract is directly between DEVA and the Vermont Public Transportation Association, and we, as the individual providers, subcontract underneath, and so we consolidate our information in that way.
So Jim, may I ask, and I don't know if you know this answer, but so is the 1.7 million, because we draw down federal funds from Medicaid, is the 1.7 million just state dollars that are needed, or is your total deficit 1.7 and we need to go to DEVA to determine what would be state dollars versus what we draw down from the federal government to get to 1.7 million?
So I would say, hypothetically, the services are eligible for drawdown of federal grants. What I can't speak to, of course, is what level of federal funds are available to be drawn down. Yeah. But if they were sitting there, waiting for state funds to draw them down, then whatever that ratio is, I think it's something like a 52-48 ratio, but I can't, I'm not the authority on that.
Okay, thank you. So what we'll do is we'll connect with DEVA and have them, I knew we were taking this up today, so we'll reach out to them and say, well, what's the match? And is it really 1.7 state, or will the state dollar be less than that? And the 1.7 is the total. So we'll work on that before Tuesday. So thank you, Jim. Thank everyone who helps provide this amazing service to Vermonters, and have a great weekend.
Thanks for your time. I really appreciate it. If you have any other questions, happy to come back and answer them.
Great.